to do roll call, please?
So Shelley,
Here.
Susan Birchfield, Mary Ann Contreras, I'm here. Wayne Dennis.
Here.
Cassandra Dillon.
Here.
Courtney Edwards. Dr. Shanoy. Dr. Shanoy, can you pronounce your first name for me? Rohit. Okay, thank you. Mark Sparkman. Dr. Sparkman. Sandra Williams.
I'm here.
Stuart Williams, not related.
Present.
Okay, thank you. Amy Bailey is not able to be with us today. They are having, Amy is the state fatality child death review coordinator, and they are having their Title V meeting today. And so she sent me a report. It says that Dishes has recently received a grant from the Children's Justice Act to support 2 full-time coordinators. One will be assigned to a rural area, one will be assigned to an urban area. They'll be announcing which areas as soon as after the coordinators have been assigned and after they receive the official award notice. Other thing that she says is the state child fatality review team is currently reviewing and updating most of the position papers on their that's posted on their website. So please stay tuned for more recent versions. And then finally, she says that they will begin working on recommendations for the 2016 annual report in November. And if you're part of a local team, please have your team start working on recommendations. They will be contacting organizations in the future for supporting information. So, next on the agenda is Sam Vance with an EMSC update.
We're just talking about this presentation.
Yes, sir. Thank you. Mm-hmm. Geez, Sam. All right, we're trying to get settled over here.
That's all right. You know, while you're trying to get settled, why don't, oh wait, I don't even have it on the agenda, never mind. Actually, I need Courtney if I'm gonna be here.
Good
That's why I
try.
took it out.
Do you want me to do it real quick?
Let's do it in announcements.
Okay.
Okay, I guess I'm about ready to go here.
Thanks, Sam.
And there's a microphone.
Anytime you're ready.
Alrighty, so a little while back, DSHS sent a survey out to all of our trauma centers throughout the state, asking them whether they have the Broslow tape and Broslow crash carts for their emergency departments. So you can see here that they sent the survey out to 190 of our trauma centers and had 100% participation, with the majority coming from our level 4 centers. And the first question was, do they treat pediatric patients in their emergency department? You can see that 99% of them do. And then they asked, do they use the Broslow tape? Is it located in their emergency department? And 100% of them do have the Broslow tape located in their ED. And then they asked, well, is it used for pediatric patients in the emergency department? And again, about 99% of them, yes, they do. The important thing to remember when you're using the Broslow tape is it should be current. And the most recent version of the Broslow tape is the 2011 edition A. And in previous experiences, a lot of folks have Broslow tapes, but they are outdated by several years. So just, that's important. Check the date on your Broslow tape. And then they also wanted to find out, are they using the Broslow or color-coded system on the crash carts, is basically what this is asking. And you can see that 94% of the trauma centers do. But what's important to remember about the Broslow tape and the Broslow system is that it's only for those pediatric patients who require resuscitation or emergent stabilization. It's not to be used on every single patient to determine their weight. If that's the case, you should be using a digital scale. And so EMS for Children, through the Pediatric Readiness Project, has developed this safety initiative, which they are calling the most important safety initiative for children, because only 1 out of every 2 of our hospitals across the country are actually weighing and recording their pediatric patients in kilograms. So, you know, with our adults, the medication dosages are usually standard unit dosages. When we have like cardiac arrest, you know, you got your 1 amp of epi or 1 amp of whatever. And kids, as we know, you're doing it by weight based, where you have 1 milligram per kilogram or 0.01 micrograms per kilogram. And that leads to issues, which one study conducted of 479 medication errors with pediatric patients discovered that over 25% of those were due to confusion between pounds and kilograms. So, and in the literature, it has been repeatedly stressed that pediatric patients should only be weighed in kilograms and should only have their weight recorded in kilograms. So again, from the PEDS Ready data, we know that nationally 56% of our hospitals across the country weigh their patients and record in kilograms. Here in Texas, 51% of our hospitals weigh and record in kilograms. Now, if we break that down by trauma service area, you can see that some of our RACs do pretty good about weighing and recording, some not so good. TSAT did not have enough hospitals respond in the PEDS Ready assessment to report their data. That's why there's nothing up there for them. So now if we look at our trauma centers, we can see that our level 1 trauma centers, 82% of them weigh and record in kilograms, 69% of our level 2s, 54% of our level 3s, and 38% of our level 4s are weighing and recording in kilograms. So what's important to point out here is that the Emergency Nurses Association created this position statement in 2012 along with the endorsed by the American College of Emergency Physicians, the AAP, the Institute of Safe Medication Practices, the American Academy of Emergency Medicine, Society of Pediatric Nurses, that pediatric weights should only be measured and documented in kilograms, that the scales used to weigh pediatric patients should only be configured to record weights in kilograms. Pediatric weights are recorded in a prominent place on the medical record, and electronic medical records should be standardized to allow only kilograms for pediatric weight entries. The pediatric patient's actual weight is considered part of the mandatory nursing assessment. And for the pediatric patient who requires resuscitation or emergent stabilization, that a standard method of estimating weight in kilograms is used, like the Broslow system. So we're doing good with that, with our trauma centers. The pediatric patient's weight in kilograms is included in an inter or interdisciplinary patient handoff report. So that is kind of what I wanted to present to you all. I know it's not exactly injury prevention initiative, but it is still a safety initiative that could lead to injury prevention initiative within our hospitals.
Okay.
It certainly does.
Thank you, Sam. Any questions from committee members?
Sorry, Sam, that poster or flyer that shows where you're supposed to weigh your pediatric patients in kilograms, is that available to order to so we can get it out to our racks, because those numbers were surprising, especially my rack at 58%. That's kind of
You mean the one that shows the individual rack?
no. Like the poster or the flyer that shows you should be weighing your patients in kilograms.
Oh.
Is that available?
You know what? That actually was produced by NEDARC, the National EMS for Children Data Analysis Resource Center. Mm-hmm. It's easier to say NEDARC. Yeah, I'll contact them, see if they have it in poster format or something like that, and I'll get back with you.
Okay.
Although I would ask, send me a reminder email, please.
Could you clarify between the separate rack percentages and the trauma center percentages on pediatrics? There is some confusion on, so M's 29%, that's based on the readiness number, not on the trauma center.
Right, that is based on the every hospital that responded within the RAC. Those trauma center numbers, percentages,
3 years ago when they did that.
2013. Yeah. So, yeah, those trauma center percentages, that was just for the trauma centers, and that was total level 1s, 2s, 3s, and 4s across the state. Does that make sense? All right.
Any other questions from committee members? Any other questions for Sam from the audience?
And just real quick, as far as EMS for Children report is concerned, just one thing I want to mention to you is that our director of EMS for Children State Partnership, Dr. Manish Shah, was just recently nominated by the U.S. Department of Secretary of, I have to look it up. Anyway, he was nominated by some bigwig in Washington to the National EMS, to NIMSAC, National EMS Advisory Council. And they collaborate with FICOMS and NHTSA and other national organizations as far as EMS-related issues. So he represents pediatric emergency medicine on that committee now at the national level.
Well, congratulations to him. And
What did you say NIMSAC was? I'm sorry.
It's the National EMS Advisory Council. And while I'm on that, just to toot EMS for Children here in Texas real quick, that because I don't think a lot of folks know that here in Texas we have some of the national leaders in pediatric emergency medicine that are chairs of these national committees, like Dr. Macias, Charles Macias, who is the chair of the pediatric committee. He chairs American Academy of Pediatrics Committee on Emergency Medicine. We have, again, Dr. Shaw. We have Dr. Kate Remick, who is on the chair of several committees, including AAP, National Pediatric Readiness Projects, as well as she is a representative to the National Association of EMTs for Pediatric Emergency Medicine. Like I said, we have several people in the state of Texas that are leaders nationally in pediatric emergency medicine, and just to let you all know that we have a lot of resources here to take advantage of.
Thanks, Sam. Actually, I'm looking through this. I believe that Texas Children's Safety Network, and you may know more about this, but the Children's Safety Network has recently received from HRSA their continuing 5-year grant or whatever. And as part of that, they are developing what they're calling the National Coordinated Child Safety Initiative. And I think COIN is the acronym. And I know that they're asking states to, and you have to be from a state health department, asking states to apply to have one of these COIN teams. And Amy Bailey had told me that Texas is planning to apply for that. Do you know any more about it, or?
I do, but I'm going to defer that to Dr.
Okay.
Shinoy since he does our injury prevention.
So that grant guidance has been, I informed Dr. Villanacci about it, and he's putting it to the DSHS group to see which department would be interested in applying for
Okay.
it. And the last date is 24th of August, so we're going to put some pressure on that.
Okay. Well, cool. It's. I mean, obviously, we want Texas represented in these areas, and so I think it's provides some good opportunities to hear about new evidence-based best practice initiatives for child safety. So, thank you, Sam. Anything else?
Nope, that's it.
Okay. Thank you. Okay, next on the agenda, we had asked Dr. Chris Drucker to provide some information about the 2013 trauma registry, and I know that Dr. Drucker has now moved to cooler temperatures. So if you'd just introduce yourself and...
Yeah, sure. I'm Dr. Heidi Boyes. I'm the unit manager of the Environmental Injury Epidemiology Toxicology Unit, and in Chris's absence, and until we find his replacement, I'll be the acting manager for the injury group and the point of contact. Chris's position has been posted, and I hope to fill it as soon as possible, as soon as quickly. But our unit, the injury group, is fully staffed. We're functioning as usual. And so I hope the transition will be smooth. And with that, I'm going to pass it on to Dr. Nina Leong to give the update on the report, on the data report.
Okay, thank you.
Good afternoon. We just have a very quick
Nina,
update.
can you speak up just a little bit? I just want to make sure
sorry.
that the folks who are watching online can hear you.
Probably Chris is watching, actually.
Hi, Chris.
We have 2010 to 2013 linked data now. It is text.crash data that's been linked to EMS, and separately text.crash data linked to trauma hospitalization data that's actually collected within our registry. So that is now available, and we're open to data requests regarding that. But that is all for any of the data updates.
Okay, thank you. We actually, the next thing on the agenda is holiday-specific registry reports, and I know one of the things that we wanted to talk about is the possibility of getting from the registry, and I don't know if in this committee, I'm looking for guidance from you all. What type of reports would we want? What holidays? Are there certain holidays that we want, for example, around the Christmas to New Year's holiday? Obviously, there's more alcohol-related crashes and things like that, and so do we want to talk about what we specifically want and make that request of DSHS? And so, committee members, do you?
So I think the whole point of this is we all know as injury prevention professionals, as ER nurses, as trauma nurses, people that work in emergency care, we all know anecdotally that there are a lot of crashes, for example, on New Year's Eve. What about Halloween? We know that there's a lot of auto-ped injuries, but we can go out there and say it, but the data is so important to validate the work that we do, especially as we move forward to the next couple of years in the legislative session, to be able to say, this is what happened during the holiday of trick-or-treating. So I think something like that. I think auto-peds during Halloween, I couldn't think of the name for a minute there. And what else would you all suggest?
Yeah.
4th of July.
Committee members, what holidays would
4th
you
of
want?
July.
4th of July?
Okay.
Yes.
Yes.
Memorial Day?
And we could include submersion as well in some of those. Is that correct? Okay.
So I've got 4th of July, Halloween, Memorial Day, and Christmas, New Year's Eve. Others?
And do we want to say specifically Christmas or New Year's Eve, or do we want to say the month of December,
Okay.
or like December the 1st through January the 5th, something like that? When people go on vacation, things like,
So if you share your findings with us in the Office of EMS Trauma, we will add that to our newsletter as seasonally appropriate. So
Perfect.
yeah, good.
Maybe consider November 15th because there's a lot driving.
Would you mind coming to the?
They can't
Sorry,
hear you
they
for
can't
the,
hear you.
and people are actually watching.
Show the summer,
You know.
100 and whatever days of summer. Two
You guys want to include spring break period in that time frame?
Yeah.
The whole month of May.
Because then you're starting to
Whole month of
want
March.
The whole month of
to
March.
stratify by month for the entire year.
Speaking to the mic.
Really, I mean,
I will speak all the way into the mic. Maybe consider extending that the December into November, because the holiday
Okay,
season
true.
really starts
Mid-November.
that week
Right.
that Thanksgiving falls on.
True.
And so we've noticed a lot of not just drinking, but other
Right.
auto-peds. I mean, everybody's out, and it's still warm usually. And on submersions, if we could quarterly, that would be awesome, because then we could see if it's with the weather or not with the weather. That's something we've been looking at in our region, is by trending by quarters, because we find that our drowning prevention people aren't very accessible to do much in the summer times. We have a really good relationship with our Corps of Engineers. And so we try to do our prevention around that. And so that's the only way we've been able to track to see if our prevention activities are doing any good. So just some suggestions.
This is what I've got. November 15th through early January, 4th of July holiday, Halloween holiday, Memorial Day holiday, the month of March for spring break. Others.
So this is not seasonal, but it's more specific types of injuries like those due to distracted driving, texting. I think we need to get the elected officials know what that burden is and how it's increasing, because I think only hard data is going to make them pass that banning on texting.
I think that's a great idea. Nina, what kind of, how good is your data on?
I would have to refer back to the data dictionaries, but I know TextDot's data dictionary might contain a data element that might contain that, but I would have to refer back to it and then get back to the committee regarding that.
That would be helpful if you could find out if the data is even available.
Yeah.
Perfect.
But as long as whatever data requests, holiday-specific data requests you guys have, just send it over. You can send it specifically to me or Erin. I know many of you guys are familiar with her. She does a lot of the submersion data reports. But if you want to specify specific time periods, then we'll restrict our analyses to that, and we can definitely provide it to you guys. We love to get our data out there. So.
Right. Okay. Yeah. I think we had a question back there. I hate to do this, but
I was just going to add, ICD-10 will help with that. So there's nothing in the register, the state register specifically to distracted driving. But ICD-10 will be able to codify that in a better way than what we've ever been able to do before.
So committee members, do we want 2013 data or do we want 5 years of data?
I would prefer 2013 and then move backwards because that's more recent.
Okay.
Okay.
Yes.
Nina, I will send you the list. I'm not going to be back in the office for another week or so, so I will send you the list early September.
No problem. That's
okay,
great.
thank you.
Thank you.
Any comments from, any other comments from the committee first? Any other from the audience? Are there other holidays or other seasonal type? Paulette?
Labor Day, yeah.
I think the Super Bowl too. I mean, that's a pretty clear one. Well,
No, I haven't.
So this is
What a segue.
This is kind of raising the question for me: is why don't we just stratify the data over the month for the entire year? Because pulling out a particular holiday. I mean, we're naming all the holidays through the year now, so we might as well just look at the data month to month. And you can know what holidays in that month.
Well, the other thing is
make more logical sense, I
specific
think.
mechanisms of injury too. September, October football. We see a huge increase in football injuries in September and October. So there's all kinds of ways to stratify. That'd be another one.
The other concept would be to designate 2 days before the actual holiday hits, and 2 days, the holiday day, and then 2 days post-holiday. I mean, to put whatever time frame that is on it, but if you want to be specific around the holiday, I think you need to be very specific with your date range versus just saying, hey, let's do it for 2 weeks before and 2 weeks after, because, I mean, that's the whole month now. We might. So we have to get specific here if we're going to do holidays.
Okay, we'll get you that information, Nina. Thank you. Okay. Next thing on the agenda is evaluation of the hospital-based injury prevention components document. The Injury Prevention Committee met in Austin on July 30th or 31st, I can't remember now. And this was one of the topics that we discussed. We have decided to start the implementation of the evaluation by sending people a survey link, and so the survey will be online. You can fill it out online. I think we ended up with 10 or 15 questions, and at what point, Stuart, are we going to try and roll that out? Is it going to be September 1?
That's what, end of next week. It's finished. It just needs to be put in the post in the live mode, and then we can distribute it, and so it can go live within 24 hours or so. But I'd say we just start it, say, either September 1st and roll from there.
So be looking for an email for this survey doc, either on or sometime shortly after September 1st. It is going to be mailed to everyone that's on the TTCF listserv, as well as to people in the RACs that are represented by the Injury Prevention Committee. If you do not get the email or the link, should they contact you? Because we want as many people to fill this out as possible.
We may be able to put the link on the GTAC website to the actual survey. Is that possible?
Colin, is that possible?
I'll check, yeah, and get back to you, sure.
Okay.
Okay. I believe so, but, yeah, let me check.
I mean, you're all welcome to email me and contact me whenever you want. That's not what I'm trying to say. But we'll try to figure a logical way to do that.
Okay. Do you have anything else to add about the evaluation?
No.
Please, Stuart?
If you get it, do it.
Any questions from the audience? Just a quick unscientific poll. How many of you have seen the document?
Not many.
Okay.
So you guys need to check it out. It's awesome.
For those who don't know what the document is, it is available on the GTAC Injury Prevention Committee, the GTAC website under the Injury Prevention Committee. It's about 38 pages. It defines 5 core components that a hospital-based injury program should have. When I say it's 38 pages, most of it is, for each component, is 1 or 2 pages. Most of the information in the document are examples of how to achieve this core component. So I highly encourage, particularly if you're a trauma coordinator, an injury prevention coordinator in a hospital, it is this committee, along with TTCF, TTAF, and RACs, spent the year of 2014 putting this together, and it's gotten a lot of national attention. Mary Ann Stewart and I presented it at a regional injury prevention network meeting in Dallas in early June. And then Stewart and I, there were some people from Tennessee there who were very interested in it, and so we conducted a webinar for them in July. And so there's ATS is interested in it. There's a lot of interest in the document, but we feel like we need to be doing our due diligence in Texas, and if we've created this document, we need some evaluation of it. And as Mary Ann likes to say, it is a living, breathing document. This isn't the end-all, be-all. We truly want information and feedback so that it can be improved.
Mm-hmm. And in the survey document, if you answer one of the questions that says, no, I did not receive this, it directly takes you to the link of the document and allows you to review it before you proceed. So if you get the survey link, please take the due diligence to take the survey and review the document. We do want your feedback.
Okay. Any questions about the document, the evaluation? Okay. Next on the agenda is this committee had decided as our project this year that we were going to undertake putting together fact sheets on evidence-based strategies for certain injury categories. We get this a lot. Oftentimes people will just say, hey, what's evidence-based? I want a program in a box. I want something I can take that you've done in Fort Worth and we can do in Dallas, or that you've done in San Antonio and can be done in Tyler and everything. So this committee decided that we were going to develop fact sheets we were going to do the research for everyone and then just have these simple, easy to read fact sheets. And we were going to color code them according to the traffic signals. So green is yes, proceed. These are evidence-based strategies. Yellow is there's not enough evaluation. That needs more evaluation. It looks promising, but we need more evaluation. Red is this has been evaluated and it's ineffective or it's harmful. So at our meeting in July, all of our committee members, at our meeting in January, I take that back, we had decided that we decided which topics we were going to select. In July, we were going to bring the information that we had, and it became pretty obvious to us within about 30 seconds that something like that, that this is a huge project, and it doesn't need to be just Shelley, Marianne, Dr. Shenoy, Cassandra saying this is what's evidence-based. And so we're going to undertake a little more rigorous approach. I believe Dr. Shenoy is going to get us, we're going to set criteria on such as this has been peer-reviewed by 3 medical journals. Anyway, we're in the process, we've taken a step back. So while we had hoped that we would have all these fact sheets that could be distributed by the end of the year, we're going to take our time and we're going to do a really thorough review. We're also going to, for different topic areas, going to engage national leaders, experts. So if it's drowning, we're going to engage some national experts as well. So all that said, it's going to take a little longer. But Dr. Shenoy, do you want to explain any more about our process? And
so, just to step back, what does this evidence-based medicine really mean? There's a lot of evidence, and the evidence can be really rigorously and well done, or it may not be so well done. And if you look at the way studies are done, some of them are done as randomized, blinded randomized trials, which has got the highest level of rigor, versus just a case series. So the evidence can be not so good, or it can be very good. So when you're talking about evidence-based medicine, you have to take all these things together in the pot, and then you kind of look at it. That's one. Now, what about in injury prevention? Sad to say, there are not very many studies done. Part of the reason is because it's too expensive. So what are you supposed to do then? I mean, you want to give some recommendations. Those recommendations can be very strong if it's like common sense stuff. I mean, you're going to watch your child, supervise your child near a swimming pool, otherwise the child will drown. So that's sometimes common sense, and you might have a strong recommendation for that. You may not have a study done to prove that. Maybe you might have a retrospective case series where the evidence level may be low. So they have something called a grade table. And that grade table is what all these universities use and all the academia use to actually decide how good these studies are vis-a-vis to use that. So that's what Shelley was alluding to, is that we hope to try to look at it in that sense. Go to each of these studies. Now, one of the questions we ask is something called a PICO question, P-I-C-O. P is population, I is intervention, C is compared to, and O is outcome. Now, I just kind of translate that into what you talk about, like drowning prevention. You'll say, okay, in a population of children, the intervention, which is like a fence, a four-sided fence, that's the intervention. Compared to no fence, what's the outcome? Do you prevent death or morbidity? So that's the PICO question we're going to try to question for each of these interventions. So that's what we are looking at, and we kind of do it. It's a long process. It takes time, and so our general opinion is to probably do a better one document at a time, do it kind of well done, rather than just kind of give a smattering of everything. So.
Exactly. Thank you, Dr. Shenoy. You articulated that much better than I did. We still feel like this, we think this is very important, not only for Texas. We hear this nationally all the time, and so far it has been done in terms of, you can go to the Community Guide for Preventive Services, or you can go to the Cochrane Reviews and things like that. And I've been doing injury prevention for 30 years, and sometimes I have a hard time interpreting what's there. And so our intent is still to do something that is easily readable, that if you're an injury prevention person, a specialist at a local health department or a level 4 hospital or a level 1 hospital, you can take it and look at it, and you will understand what the data says and what the information is. Our intent is to do the hard work and make it readable. So, yeah, injury prevention for dummies. Are there any other comments from the committee about that, or?
I think you all, and me, I think I will at least find, speaking for myself, find it really helpful because, we're always looking for the academia side of what we do. We do it with our hearts, but we need to balance that with the academia side in the proof, because in the long run, the outcomes will be tremendous and the opportunities there. And I applaud Dr. Shenoy for putting us on that track, although it means we'll probably have to meet about every other week and have a lot of homework. I think there will be a lot of value in each document. So they'll be slow to come out, but each one will be so worthy. So I hope you all will like it.
So one of the things that we need to decide as a committee is what which one are we going to do first. So any comments from committee members about what we tackle first? My suggestion would be something where there is probably some good evidence already. Right. Unfortunately, youth violence is probably not going to rise to the top of our list. But Stuart?
I would align it probably with the most common injury, so that's either motor vehicle crashes or falls.
Right, I would too. So both of those, there is some good evidence out there already. Okay.
That was 2. You guys have to narrow it down further.
Well, I mean, if we're talking about doing, it's a good place to start. Any comments? Go ahead, Dr. Shenoy.
So now Stuart's saying motor vehicle crashes, right? But now there's a huge thing. If you look at the horizon, it can be child passenger safety, it can be drunk driving, it can be like everything. So you have to actually pinpoint a question. So that's why I bring it up. Now there's good evidence. I know already it's published in JAMA. Like you put in like a child safety seat, and Dr. Durbin and Associates in Children's Hospital of Philadelphia showed that you got a 57% reduction in mortality based on that. Well, so that's the level of data already there. So you don't want to reinvent the stuff, but you just want to get it together. So my suggestion is pick up a question. Like I said, the PICO question is specific to what you want to use. Like, now, backtracking a little bit, you want this document to be useful to grassroots people, right? So that's where I think you should start. Is what do you think they would need, and then prepare a question back.
Well, why don't we turn it over to the audience?
So what is it that you all have that you need more information, or maybe you need more verified scientific academic information in order to do the work that you do out in your communities? What are you seeing? Don't all jump up at once.
Traumatic brain injury. Mark, do you want to address that?
Large and interesting topic. Again, I think what Dr. Shenoy was talking about, really what we want to do is probably try to define our population and look at the particular intervention and where to go from there. I would probably say one of the data points that we asked for from our folks over here was talking about texting drivers in accidents.
Distracted driving.
Mike?
Yes, Mike, can you turn the mic to you?
I'm not going to repeat any of that. So,
even closer. Closer. Yeah, there you go.
I think what Dr. Sparkman was suggesting is that we looked at the texting and driving issue.
Yes.
That's certainly something that if we have information, we can provide and be ready for the next legislative session.
I think that would be a great topic for us to look at. We're already looking for the data anyway. There's some research out there. It's kind of a hot topic in terms of what's going on in terms of cities and counties and legislature. So it'd be a good one to look at, I think.
I agree with you, Mark. I think that's a good topic to look at.
Okay, we'll do the texting and driving. Mary Ann mentioned, I mean, should we do something that's child-focused as well as pick another one that's adult-focused, such as older adult falls? I know, I think at the workday
Distracted could go with anybody, but.
it could.
Even then, like, yeah, trying to narrow it down even more than that. See, this is how complicated this gets.
Right.
And this is what we discovered in our workday meeting. But like even older adult falls, do we focus on nursing facilities, or do we focus on at home, or do we just make it a generalized approach? I mean, these are questions I think we have to answer.
It really falls into your basic definition of your population study and what you're looking at.
Mm-hmm.
If I may suggest, we do just one at a time. Let's take our steps and move forward. And we're kind of showing these poor folks our inner workings. So
Good idea. Okay, committee, are we good with texting and driving?
I think I agree with Dr. Sparkman. I think doing one thing at a time, and then as we get into it and discover where our weaknesses are or areas of the whole process that we need to develop, maybe the next one we'll do a PD and an adult view or something like that. I don't know, but
Okay.
I think that's a good point that you make.
So at our next workday meeting, that's what we will do is start looking at the criteria. So committee members, Dr. Shinoy, Dr. Sparkman, others, maybe send some suggestions so we can start working on that at our next committee workday meeting. Okay, any comments from the audience? Any questions about that project? Is this something that will be of value? I mean, this is going to, we think it is. This is something that is going to take a lot of time, but we want it to be useful. So I see some people nodding their heads, but Colin?
Well, I just sent the World Health Organization's Child Injury Prevention Report to the three of you, and they have a pretty good methodology for rating evidence-based policy for injury prevention for children. So.
Okay. Okay. All right. Making progress. Next thing on the agenda is a discussion about a potential state injury prevention conference in Texas. We actually did discuss this at our workday meeting in July, and we've had, there's actually been quite a bit of discussion about this. We talked about the possibility of doing a very small, probably limiting it to 30 people or so, and just doing what we were calling a leadership symposium, leadership summit of 30 people or so to learn just how to use different tools that are available to select interventions, to do evaluation, to evaluate policies and things like that. We have set tentative dates of May the 2nd and the 3rd in May 2nd and 3rd, 2016. But we, several of our committee members, Stuart, Courtney, and Mary Ann, presented at the TTAF TIPS conference on Monday. And there was some discussion about not including, in addition to a leadership summit, possibly having a one-day statewide injury prevention conference. There was several people that mentioned that we hadn't done this since 2012, that there is some value, there's some interest there. So what we're looking at trying to do is plan a one-day conference which would be held on May the 4th. So the Leadership Summit would be kind of a precursor, pre-conference workshop, and then a one-day conference on May the 4th, 2016. We were talking about potential locations. I think that we are almost decided on San Antonio. Sandy Williams, Jennifer Northway are both in the San Antonio area, have access to facilities, could help with the planning and things like that. So we don't have a save the date yet, but you might put on your calendars May 4th, 2016. Look for information to be forthcoming. And we're also interested in, this is going to be the GTAC committee members will be planning this, but if there are others who would like to be part of the planning, we would certainly welcome stakeholder input. We think that there is some funding available to do this, so that's always a good thing. In the past, Dell Children's has basically underwritten the cost of the conference, and we're looking at additional funding for that. So, committee members, do you have any comments? Any comments from the audience? Anybody want to volunteer to be on the planning committee? Well, if there's interest there, please see.
We are a fun group to work with. I mean, really, we are. So really consider it and see any of us after the meeting.
Any general public comment? This is going to be a quick meeting. Yes.
Oh, yay.
Hi, Linda. You know the drill.
Hi, everyone. One thing I noticed that you haven't talked about, and I don't think it's really too early to start talking about the next legislative session. Since I've been involved in the injury prevention field for quite a while, too, I think it's time we hit the motorcycle helmet thing again. It's embarrassing, really, what's going on in our state with respect to motorcycle helmets. So I just wanted to put a word in for motorcycle helmets, and that maybe the landscape has changed. And one of the ways that we're thinking about hitting it is looking at the numbers of people who have traumatic brain injuries, who don't die, who are then left to be cared for by the state, and how much money that's costing us. I mean, it's a terrible thing to have to look at it from an economic viewpoint, but if that's what's going to move it forward and put some sense into the legislators' heads about the fact that we need motorcycle helmets, then that, I think, is a way that we can approach it. So I just wanted to put a word in for that, and that it's, again, not too soon to begin to mount a campaign.
Thanks, Linda. And I just, I can put that on the next agenda. I just want to be sensitive about what I can and can't put on, because this is a DISH's committee. But we can ask for, reports from the trauma registry on motorcycle-related head injuries. Colin, what can I put on the agenda?
For the next meeting, yeah, so discussion regarding motorcycle TBI, I would say, yeah.
Got it. Thank you, Linda.
Does it have to be specific, or can it be discussion around
Yeah, I'll talk to Phil Lockwood about
policy?
It. I think it has to be more specific, and it'll probably be kicked back from legal if it's not specific. So let's talk about it, though. Yeah.
Okay.
Any other general public comment? Okay, I think we I'm sorry, Jen?
I just actually wanted to remind folks, I know that there was a lot of discussion regarding the evidence-based recommendations and how that wasn't going to come out as quickly as expected, but I do think a very valuable resource that maybe people are not using as much is the spectrum of prevention documents that are housed on the GTAC injury prevention subsite. And just as a reminder of all of the different topics that are covered, it includes alcohol-related related crashes, child passenger safety, child maltreatment, concussions, drowning, intimate partner violence, residential fire prevention, older adult falls, pedestrian safety, teen driving, and then of course there's a glossary. So those are already some things that have been produced by this committee, that are some great recommendations on different levels depending on manpower and resources, and I think those are very applicable for facilities, whether they're a 1, a 2, a 3, or a 4. Maybe they're a less than a part-time shop, or maybe they have staff. So I wanted to make sure that those were also highlighted as a resource in the interim as those other pieces are being developed, because I think they're very helpful.
Thanks, Jen, and thanks for reminding us about that. Yes, that was also another year in the life of the GTAC Injury Prevention Committee to develop those. So, okay. Any other public comment? I think we have several announcements. We'll start with Sandy, if you could talk about the TTCF meeting. By the way, Courtney is not with us today because we are hours away from the new move, or the move to New Parkland. So 6 a.m. tomorrow morning, New Parkland opens for business.
Okay, so we met yesterday. We had a couple of presentations. One of them was from University Hospital on their Life Image program and how it's helping to reduce the use of continued CTs or additional CTs when patients come into their hospital. Also, we had a presentation on registry and how trauma program managers can use their registry data to drive their PI programs, but also to help drive injury prevention initiatives in their hospitals. They did a good section on Ask the Surveyors again. For those of you that are not aware, we have TTAF supplies the surveyors for the trauma surveys, and so there's a section in our meeting to where new trauma program managers in the meeting can ask surveyors questions, and a lot of that pertained around how to use your registry again. And there's a big focus when you survey now on how you're using your registry to drive your injury prevention initiatives. So that was a very good conversation. Our next meeting will be in November in Dallas. It'll be that Friday, November 20th. The meeting starts at 10 o'clock. And we are also creating a flash drive for documents for trauma program managers to use as a resource, and we are doing a section in that flash drive that concerns injury prevention, and so we'd like to upload the hospital-based injury prevention components into that flash drive, so we'll be putting that on there also. And that's it.
Thanks, Sandy. Any questions for Sandy? Great idea about the flash drive. Okay. Do Stuart or Marianne, do you want to talk about the TIPS symposium that was held on Monday?
Stuart did a fantastic job. I think that the TIPS conference was well received. The organizers from the TTCF and TTAF group were phenomenal. They made it really easy to not only speak but as well attend. There was very rich content, and it was really well attended. They had 65 folks out of 70 registrants. So, and there was a lot of new faces there. It was a great venue, wonderful food, and if you guys didn't go this year, I highly recommend that you go the next time.
Good job, Stuart.
Just do it, right.
Stuart and Marianne both did a very good job, as did the other speakers.
And Courtney.
And the other speakers. As well as the other speakers. Another announcement that I have is September 1 will open up committee applications for GTAC, and we have 2 unexpired terms that will need to be filled for the Injury Prevention Committee. One of them is Susan Birchfield. Susan will be retiring in November. Her term was not to expire until 2016. So we will need to fill that for a year, and then once somebody is named into that position, they can, of course, reapply. Also, I was hoping Susan could be here today. Susan, many of you know Susan. She's a long-time injury prevention coordinator in Texas. Had a very very good career, and we wish Susan all the best in this next phase of her life. If you guys run into Susan, be sure and tell her happy retirement and mention that we wish her well. So the ones that will be expiring, Courtney Edwards' term will be expiring, so I will get with Courtney to make sure that she knows if she is still interested, will reapply. My term will be expiring, and Cassandra, you are filling an unexpired term too, so you will need to reapply on. And I think look at the Dish's website sometime after September 1. It will be due, I think, September 30th. But we have two other, like I said, Susan will have an unexpired term, and we have one other unexpired term. So if there's anyone that is interested in becoming a member of the GTAC Injury Prevention Committee, we would certainly welcome you. We don't have as much representation from rural or frontier areas or out west or anything like that. So particularly if you are in those areas, we'd love to have you come on board. As Marianne said, we are a fun group, but we do work a lot. So just want to make everyone aware that prior to the next GTAC meeting, you will need to apply if you're interested in committee membership. You have an announcement?
Yes, I do. I have a commercial. So you probably have seen, as you sign into the different meetings, this little brochure flyer that says save the date. At JPS Health Network, we're having our 5th annual trauma conference in Fort Worth. We would love for you to come. Fort Worth is a great venue. It will be held at one of our local community colleges in downtown Fort Worth, which is just a fabulous place to be. When you pick this little flyer up, it has a link on the bottom that you can go to and register today. We have a robust registration already. We would love for you to come. We have speakers from Duke University, Dr. Mark Shapiro. We also have Dr. Havens from Brigham and Women's, who was involved in the Boston bombing incident, who's going to talk. We have Dr. Stoudemeyer from Stanford University. We have some fantastic speakers, is my point I'm trying to get across. And we feed you all day long, 7 nursing CEs, and for $75 for nurses and $50 for pre-hospital and $125 for physicians. So, I mean, that's a great value. So we would love to have you and see you in Fort Worth. Thank you, Shelley.
What's the date?
I'm sorry, October the 16th. It's an all-day Friday thing.
Stuart, do you have an announcement?
Yeah, just to give you all, if you haven't received the flyers that have been sent out, not by myself, but the AAST annual meeting is being held in Las Vegas. Many of us are not able to attend that meeting, but they are providing a virtual ability to attend via your computer. And that is on Wednesday, September 9th. And it's most of the morning, 7 a.m. to 11:30 a.m. And I can get the flyer to whoever to send it out. It has the information on how to connect virtually. So, and that is the Trauma Prevention Coalition of AAST that's meeting.
And thanks, Stuart. And I believe Courtney is presenting at that meeting, so she will be on site in Las Vegas. But this is a nice opportunity for others who to attend virtually. Our next meeting, the Injury Prevention Committee's next meeting, is going to be Friday, October the 30th. It's going to be in Fredericksburg. Thank you, Wayne, for securing us a location. It will be at Hill Country Memorial. I have the address. Again, it's going to be in Fredericksburg on October the 30th. We'll meet from 9 a.m. until noon. And Wayne has provided a list of several local hotels, lodging within the Fredericksburg area. We welcome anyone to attend our meetings. Our last meeting in Austin, we had several people as guests and stakeholders. So we're always anxious to get hear input from everyone. Committee members, any last comments? Members of the audience? Sure.
Hi, I'm with the Office of Acquired Brain Injury, and we just wanted to let you guys know that from August until November, there will be concussion prevention PSAs being screened in over 400 movie theaters within the cinemas throughout Texas. So keep your eye out for them. They are the message is, when in doubt, sit it out. And so they're about 30 seconds long. They include a real professional football player who I don't know. So there you go. But keep your eye out for it and let us know if you see it, because we would love to know that, they're being showed.
Do you have links to that? I'd love to be able to put that on like our Injury Prevention Center website or.
Yeah. I think so. We'll have to ask if we can share the link that we have, though.
Sure.
But yeah.
Okay, thank you for that announcement.
Additionally, September 19th is National Child Passenger Safety Car Seat Check Saturday. Lots of events happening across the state. If you're a car seat tech, I hope that you're participating.
Okay, and finally, I just want to say thank you again to TTAF for broadcasting. I don't know if streaming, I guess, is the right terminology, for continuing to do this for all GTEC meetings. It's a great resource to have, and something that people can take advantage of. I have nothing else. We're going to give you 29 minutes back in your day of free. Dr. Sparkman, do you have something?
I just have one question. Do we have the date and time for the November meeting?
Yes.
Yes, somewhere.
Let's see here. Hold on.
We're usually on Saturday.
Yeah.
The Injury Prevention Committee usually meets on Saturday.
So those meetings are Saturday the 21st, Sunday the 22nd, and Monday for the main GTAC meeting, 23rd.
But the committee times haven't been decided yet?
Committee times, no. I believe they will be the same as they are now.
So it's likely we would be 1 to 2:30?
Yes.
On Saturday the 20th?
Yeah. We will finalize that and let folks know soon.
Okay.
Yeah.
Right, 21st. All right. Thank you all. The meeting's adjourned.